What's up, guys? Melvin from hairtransplantnetwork.com. Yesterday, I had a fantastic podcast with Dr. Camacho. Unfortunately, there were a lot of technical issues, so I'm going to re-upload the stream, and I'm going to include some of the parts that were hard to hear and some of the parts that people were complaining about. I'm going to go ahead and redo it right now. All right, so I had the pleasure of speaking with Dr. Sergio Camacho, Bogotahairlines from Colombia. He's doing excellent work. Guys, I suggest checking out his Instagram at Bogotahairlines. I'm going to go ahead and include it in the description as well. I want to first talk about this repair case. There's been a lot of talk about repair cases, and someone on the forum requested that we break down a repair case on the live stream. Unfortunately, as I mentioned earlier, there were a lot of technical issues and a lot of pictures that were missing, but here I'm going to break it down. So this patient went to a hair mill and had 3,400 grafts. Okay. What you guys have to understand is when a clinic says 3,400 grafts, that doesn't mean that they attempted 3,400. If the transection rate is high, they can make probably 6,000, 7,000 holes in your scalp. And maybe out of those 7,000, only 3,400 are viable. In this case, 3,400 was transplanted to the top. The growth was very sparse and very unnatural. But the worst part was how his donor looked. Take a look at his donor, absolutely obliterated. When he shared his pictures with Dr. Camacho initially, they thought that his donor looked a lot better because it was grown out. But once they shaved it down, they were like, oh man. Unfortunately, in a lot of cases, there's not much you can do. Thankfully, Dr. Camacho was able to get 2,038 grafts, and he was able to restore his hairline and get pretty good results, all things considered. Now, the reason I say all things considered is that a repair patient is never going to look as good as someone who did it right the first time. This is why it's so critical, guys. Do your research and do it right the first time. This is why I created this podcast. This is why we created the Hair Restoration Network, and this is why we created the Hair Transplant Network. It's to educate you guys so that you do the right thing the first time. Never let location, cost dictate your choice. Always look at results. Results trumps everything. How often patients away for not being candidates?
The main reason why I decline a patient is because the expectations he has are far away of what we can do, because especially because the donor is not enough. The first time a guy came with a picture of this model, I thought he was joking, and I laughed, and I made the mistake of laughing. But then I found out that he really wants to look like this guy who was 40 years younger, and he has a full head of hair. So that's the principal reason why we decline patients, is because the expectations are far away from what we can provide. We do Norwood 6, Norwood 7. The donor is the limit. And many times of these guys with Norwood 6 and 7, they have hair everywhere else. So we can provide from the... I never go up from the chin. I always do the neck. Not higher than that, because I'm concerned about scarring in the face. That's I'm very scared of that. So we do the hair below the chin and chest if possible. But the reason we decline is because the expectations are crazy high.
Yeah, I think some guy who sent you a picture of somebody with unrealistic expectations. I think that's one of the biggest things that people don't understand, and what I always try to tell people, like, look, hair transplant surgery is not a miracle. You're not, like, doctors are not magicians. They can work with what they're given, and your donor supply is just like, think of it like material, right? If you have material to build a 2-bedroom house, that's all you're going to get. You can't be requesting for a mansion with only enough material to build a 2-bedroom house. So I think that's definitely a big thing.
The amount of bricks available for the castle or for the 1-room apartment. Yes.
Yeah. And so somebody asked if they if they already had a hair transplant with one previous clinic and they want to return to you or they want to go to you, how would they go about that?
The idea, we can start looking at the pictures to follow up his progression and everything, but at least we have to wait a full year to see the final result, because it takes a full year for the, or even more, actually maybe 14 months, to make sure that everything that was implanted in the first surgery has grown. Then we can start to think about a second procedure, because sometimes some hair is not popping yet, but it's still there. The root is fine, everything, and it's gonna grow. And if we place a graft on an existing one, we're going to ruin both. So at least 12 months of waiting.
Yeah, I think it's super important that any ethical surgeon, if you had a hair transplant like 5 months ago and you're like, hey, this isn't growing, need to go to someone else, it would be insane for another surgeon to say, yeah, come and do it. I mean, I don't think, honestly, I think you should wait at least 12 months, unless the only time that I would say you don't have to wait is if, let's say, you had your hairline done 3 months ago and you didn't touch the crown and you want to go to another clinic, then that's fine. You can go at any other time. It doesn't really matter. But if you're working the same area, wait the full year before consulting with any other doctor, because you don't really know what it's going to look like until the full year.
Completely right, yes.
And the next question we have is, do you extract from the lower beard, um, or fill into the mid scalp?
That's the special cases when there's no donor in the head. But yes, when we have to reach other areas, I do it from the lower beard, again below the chin, and the idea is to put the those grafts spares in the, not in just location, but spares to make things more smooth.
So it's on special cases that you use beard hair. Um, for Norwood sixes, we had a question earlier on the forum about Norwood sixes and whether or not you reject Norwood sixes just because they have extensive baldness. What's your view on that?
No, no, everybody deserves the opportunity of a hair transplant. And usually, what I recommend is, let's work in the front line, the frontal part, because that's the more noticeable part. When it grows, you can comb your hair back and cover more, and it's going to look natural. That's one possibility. The other possibility is, what, with the limited amount we have, we can place the whole head, but then think about scalp micropigmentation. Just so with the transplanted hair, it looks like the micropigmentation looks more natural, looks 3D. But usually those are the choices. Or the front, that is more important visually, or in the whole head, but thinking about pigmentation.
Yeah, I agree. I'm glad to see that you are able to do Norwood sixes without rejecting them. A lot of clinics before would reject Norwood sixes and people with extensive baldness. We got another question here. What do you tell patients who can't take oral finasteride or can't tolerate it, that or topical minoxidil and other hair loss treatments?
I am a fan of both the only FDA approved medications, Finasteride and minoxidil. So I trust them. I see how they really work. It's a commitment treatment. It's not like a month treatment. It's a many years treatment. um, Both works fine. I don't know which one works better, actually, because a lot of patients do better with minoxidil. A lot of patients do better with finasteride. Minoxidil has the advantage that doesn't have the sexual side effect, so people are more confident of using minoxidil. But finasteride is also so good, and the side effects are so uncommon that I do not recommend them. FDA approved them, so I am in the safe side. Um, when the patient doesn't tolerate the medication, what I say is, you have to adjust the dose that is good for you. FDA says that finasteride should be taken 1 milligram per day, but maybe you have to take it every other day, or 3 per week, or 2 per week, or adjust your dose. And that's the best thing, because it really works. It doesn't work the next day, but it really works. It's like the fertilizer for the existing hair, or let me say, for all the hair, right? So the difference of topical or oral finasteride is, at the end, both ways are going to get into your body. Of course, the topical one is going to be much less, and it's going to be the located effect. So yes, if they don't tolerate the oral finasteride, I recommend the topical one. And again, to start with very low doses, and then move up as high as they feel they don't have side effects. And basically the same with minoxidil. Now the minoxidil is a medication that was invented for high blood pressure, and as a side effect, they said, oh look, especially the ladies were complaining about beard and facial hair. So that's why they started to give it to patients with hair loss, and then because the side effect of lowering the blood pressure, that is also a important side effect, because the problem is that if you stand too fast, then you may fall down and you may bump your head, or you may get headaches. That's the side effect of the principal side effect of minoxidil. So that's why it was given topically, but the side effect of giving it topically is the exposure to the sun. So sun with minoxidil it turns your scalp into redness and itching, and actually sometimes painful. But I trust
Yeah.
in these medications completely. I recommend them to almost everybody.
Yeah.
Yeah.
Yeah. I mean, I think, the thing about medication is that it's a preventive measure. It's something that you don't have to continually keep getting more hair transplants, because, as you mentioned earlier, hair loss is progressive, and maybe in when you're young you lose the front, but then as you get older the middle starts to go, and then the crown starts to go. So if you're on finasteride and topical minoxidil, that's going to prevent that from happening, or at least slow it down. If you can't withstand it, I definitely 100% agree that you should try to adjust the dosage. Take it at a low dose, because something is better than nothing. Um, so yeah, I definitely agree. We have another question here, and I'm gonna try and see if we can play the video that we have of your clinic doing work. They asked, who does what? What does the doctor do versus what does the technician do? The grafts into the slits. So basically you do the extraction, you create the slits, and you're assisted by Dr. Paola, which is your junior doctor, who also
Yes.
does the extractions as well, if I'm not mistaken, right?
Yes, completely right. We are two teams for one patient. So the technicians, I'm gonna talk a half. Let's talk about my left side. Two technicians are loading the implanters. One technician is passing me the loaded one and receiving the empty one.
Yep.
As part of the team for the this step that is the implantation step, and for the extraction step I do the extraction, and the rest of the team are under the video microscope, under the stereoscope, is taking care that the grafts are classified right, and that there's no transection or damaging of the grafts. And very important to keep them always very hydrated, because that's another reason how
Yep.
the grafts can be damaged without noticing it. Yes.
Yeah, and the grafts can dry out without being in the right holding solution. It's so important. Just what type of holding solution do you use? Hypothermosol,
I use saline and I use
saline,
the plasma of the patient.
saline and plasma.
Yes.
Okay, looks like we have another question. What is the yield and growth rate of the grafts, would you say? I was like, what is the percentage of yield and growth rate for your practice?
Look, if you do things right, the whole, the extraction and the implantation, the rate should be close to 100%. So what may happen is that you don't realize that you during the extraction you transect one. So at the end it doesn't count, because if what's transected, it should not go into the count, But I did a damage transecting one. So let's suppose during the transaction I didn't transect no grafts, so I have 100% nice graft, and then during the implantation, during the loading of the implanter, if it is done right, again we should have 100%. But maybe during the loading, the technician has ruined graph. So we have to be very, very careful about each step of the procedure. If we do things right, the answer should be 100%. But sometimes, again, dehydration with the forceps. We don't use forceps anymore because we are using the implanters, but we use forceps to load the implanter. Sometimes we use forces if the graph is a little bit outside. We have to put it the right direction, or push it a little bit deeper. So, but the answer should be 100%. I may say we have a 95.
95. That
So some cases are very difficult. Curly hair, that's a challenge, because the extraction is difficult, because the placement in the insertion in the implanter is difficult, because usually those patients bleed a little more. The scalp is
mm,
a little harder, so it's a little bit challenge. So of course, then the survival rate is going to be a little bit lower, but the idea is to be close to at least
close
95.
to Yeah, close to as much as 100 as you can get. Yeah, I think 95 is a good number. We got another question here. Do you utilize chest hair as a donor source? And if so, what is the growth rate for chest hair?
Look, chest hair is a situation that I want to avoid, but sometimes we offer it. One of the biggest problem with chest hair is that to extract, you have to numb a big area, because the density in the chest, so it may look very good, but the density per square centimeter is very low. So
Mm,
very fast we reach the safe amount of anesthesia that we can inject. So when we do chest, usually we are very limited with the amount available and with the amount that we can start because of the anesthesia. The other problem is that the hair in the chest is much more attached to the rest of the skin. So sometimes you have to pull the graft very hard and it doesn't come out. So that's another problem. And the direction is crazy. So that's a last measure resource of hair. Yeah,
yeah.
yeah.
So what would you say, like, on average, how much does chest hair grow? If scalp hair is 95, what would you say chest hair is?
The amount we extract, I may say also 95, but many times if we want to extract, let's say 200, we at the end we extract only like 50. So it's gonna be like a 25 goal of what we wanted to do. But
Mm,
it's low, it's low. Yeah.
okay. Yeah, that makes sense. We got another question here. Why do some hairlines still look receded even after a hair transplant? And I think this person refers to why are some hairlines still like a V shape and not necessarily that straight shape that a lot of obviously people want.
That's interesting, because sometimes, or many times, the patients come asking for a hairline that is so low with no recessions. I call this the chimpanzee project because they want so low, and that has two problems. That we're gonna need too many grafts to lower the hairline as low as they
Yeah.
want, and then we're gonna have no reserve, or we're gonna have not enough hair for the rest of the head. And many times, as important, it doesn't look natural because men, we have recessions. We have recessions. So,
Yeah.
so line with no recession is more like a female pattern hairline. So that's the reason. And the more recession we leave, the more natural it looks. And especially in a young patient that I hope is going to turn 40 and 60 and 80. So if we have done a very low hairline, when he turns older, it's not going to look natural. So we have to think in the long term. So two reasons: save graft and think about the long term.
Yeah, those are you hit the nail on the head, pretty much. You don't want to fall into a situation when you have like super low hairline, everything else is gone, and then now you just have this patch of hair that looks weird, and it's just like an island of hair. That's not a good look. um, yeah, we have another question. How many grafts per square centimeter in the hairline versus the mid scalp and the crown do you usually do?
This is very important to differentiate. In the line, we only use the one hair grafts, then the twos, and then the threes and fours. If we place graft with two or three hairs in the front, it's going to look like plugs, it's going to look like a doll hair, and it's not going to look
Yeah.
natural. So the densities, so we have to talk about how many graft of one hair graft in the front. We try to get as high as 60 because they are the little ones, the one hair grafts. Once we go towards the back, we can use a lower amount of graft per square centimeter, let's say 40. Usually, the patient is not completely bald, so we have
Yeah.
to consider that they still have hair there to do the calculation of how many graft per square centimeter should we place. And of course, again, when the donor is limited, we want to have high density graft per square centimeter, but the donor is not going to allow us to do that.
Yeah, I think one thing that people should realize when they're asking about grafts per square centimeter is that um, your hair thickness matters, right? Because if you're a person with super thick, bushy hair and you do about 40 grafts per square centimeter, that's going to look like 100 versus someone with that really fine wispy hair. So the numbers don't really matter as much as how thick your hair is and how much hair you actually have, right? Because you could do 40 grafts of just mostly singles, and that's 40 hairs versus someone who does 40 grafts and they have almost all triples and quadruples. They're going to
Exactly.
get way more dense looking results. So don't get too caught up on the numbers.
Yes, that's exactly the truth. And this is something very important to mention. The bigger the punch we use to do the extraction in the back, of course, the more triples and quadruples we're gonna get. But then the problem is that the scar, the rounded scar, because FUE leave you scars, are rounded, spares and everything, but it leaves you scars. So the bigger the punch, the diameter, the bigger the scars in the back. So that's a trade-off, bigger graft, but bigger scars in the back.
Yeah, yeah, no, absolutely. We got another question here. What are the max grafts per day that you do? I know it may vary from patient to patient.
My limit in one day is 3,000, 3,100 something, but 3,000 is the limit. And honestly, not because of me, but because of the patient, because being seated in the chair for more than 8 hours, then is too much. It's much too much for everybody. So if the case deserves more than 3,000, we do it in 2 days. That's the way we do it.
So 3,000 grafts max, and that's mainly because, of course, for those who haven't had a hair transplant, 3,000 grafts, that's a long day of just sitting there and not. If you guys have ever gotten a haircut, imagine a 10-hour haircut, where you can't move and everything. So yeah, I agree. Um, We got another question here. Do you work on the temple points, meaning the temple peaks? Because a lot of clinics do not. And if so, what's the type of artistry or how do you work on these areas?
Look, the lateral peaks are so important because they reframe the face. So it's very, very key point in the design of the hairline to include the peaks. The importance, or you have to be very careful because the density usually is not as high as the upper part, and of course the direction of the implantation, because they usually grow downwards, so we have to place the graft like the opposite direction so it grows down, and we only use one hair graft, maybe the finest one for the lateral peaks. If we place a two hair graft in the lateral peaks, again it's going to look pluggy and it's going to look not natural, but very important to consider to restore the peaks. Yes.
Yeah, no, I agree 100%. I think that the peaks are definitely important. We got another question here. What is the shortest time? But
Let me, Marvin, Melvin, let me tell you something. And many times the patient doesn't know that that's an important part of the restoration. So we have to look. You may need something in the sides, and then they realize, oh yes, of course, let's do it.
yeah, a lot of people don't. I mean, it's just barely being touched on now. I got my temples done, and I have to say that I was looking at my pictures from my wedding, and I was like, oh man, I got to Photoshop these in because you don't notice it, but it makes a huge, 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 huge difference. We got another question here. What is the shortest time between hair transplants in the same area? Meaning, someone got the hairline done, and they want to get another hair transplant. What's the shortest time they can wait before they get the hair transplant in the same place?
It is very similar to the question before. We have to wait at least 12 months if we are going to work in the same area. Other areas we can, as you said, we can start much earlier, but the same area at
Yeah.
least 12 months.
Yeah, I agree. I mean, I think the reason why that's important to wait is because hairs are still growing, and you don't want to implant a graft in a graft that's already going to grow there, and you're just going to damage things. So it's best to wait the full 12 months, see how it's going to look, and then get another one. We got another question
I can say
here.
while waiting, use the medications. They should
Yeah,
use them.
absolutely, absolutely. We got another question here. Do you use manual or motorized punches, or do you use both?
I nowadays I only use the motorized. I use the Mamba Trivolini device. I love it because the key factor, it has many important things to consider. That's why I like it so much. First, the movement that it does is at the beginning. You can choose which movement you want, right? But usually the one we use normally is a rotation movement and then the Mamba movement. The Mamba movement is a synchronized movement. It's like a vibration. So it loses the lower part of the graft without the risk of transecting it. So rotation for the epidermis, that is the hard part, and then the vibration for the lower part. With that, you get beautiful grafts. Another beautiful thing the device has is that it has suction. So it presents the graph. If the patient is bleeding, this bleeding here is not risky, but it allows you not to see clearly. So you have to the cleaner the area, the better. So it cleans, it presents, it does the vibration movement, and you can choose how deep you want to go, and it has also oscillation movement. It has and it has something called a smart react that
Mm,
avoids to use the pedal. So when you touch the tip of the punch, and it does like a vacuum, then start the movement. So you don't have to coordinate the pedal every 3,000 times. So
yeah,
the machine starts automatically. That's a beauty. I love that machine. Of course, the
yeah,
hand of the Indian is
yeah.
important, but the machine helps a lot. This device helps a lot.
Yeah, yeah. I think that There was a lot of talk before about the manual versus motorized, and I think the technology has advanced so much now that personally, I think the motorized, if you have a good motorized tool, is better. Of course, there's still some people that are really good at the manual, someone like Dr. Mwamba, but
Yes.
yeah, I think for sure.
And another thing that this device has is that you can control the timing of each part of the movement. So, for example, if we are doing a case that the scalp is very thick, instead of leaving the rotation for 100 milliseconds, we can leave it for 200 or 300. So it starts that part and then the other movement that we have chosen. So that's very important. You can calibrate the torque and the time. So and you can try different positions when you're starting the first graph to see which one fits the better, and of course the diameter of the punch. We can do the
Yeah.
0.85 to up to the 0.95. That's the bigger diameter I use. I don't do bigger than 0.95. And something very important, the diameter is of the external area of the punch, not of the internal area. Because sometimes I see punches that they say like 0.8, and then you do the you use the I forgot the word to measure the caliber, and the
Yeah.
caliber is not of the outside. It says
It's in
zero
the
point 0.8
inside.
inside, but it's 1.1 outside. So that the difference is huge. The scarring is going to be completely different.
Yeah, we're gonna wrap it up pretty soon, but we have a couple of questions. I know someone in the chat asked if the trivolini system, the Mamba, is like the NeoGraft. Absolutely not. The NeoGraft is something that is synonymous with like technicians that don't know what they're doing using it. The trivolini Mamba system is actually one of the best extracting devices on that we have. That and the Devois Wa system; those are, I would say, probably the top two. Um, we have a question here that asks, do you mathematically calculate a patient's donor to know how many grafts they have for, in total? So let's say a patient comes to you and they're in Norwood 6, and they want to know how many grafts do I have in total, my lifetime grafts. How do you calculate that? Do you have a coverage value or anything like that?
Yes, I want to mention that many of the consultations are via photography or video consultation, so we cannot have the opportunity before they arrive to do the exact maths. And the idea is to do the math once the patient is completely trimmed, because the difference of densities and fiber caliber changes if it's the occipital area or the parietal area. So the idea is to have the patient alive, and with the trim hair. And yes, we do the calculation. We choose square centimeters to do the coverage value. That the idea is to have a coverage value above 5.4. That's the number that at the naked eye it is going to look with a density that is normal. So we have to calculate the coverage value of the donor to see how many grafts we can extract, and of the recipient to see how many grafts we need. And yes, we do the math to do it.
Yeah,
It
yeah,
takes
no.
time, and you have to, but the idea is to, especially in cases when the donor is very limited, or the ball area is very big. Yeah.
Yeah, I mean, I think how you approach it is really great. I think that that's going to set patients up to know in the future how many grafts can safely be extracted. Because at the end of the day, it is sort of like mathematics, right? You have only a certain number of grafts that you can use, and that's it. Your number is finite. So I think the way you do it is really well. I'm glad to see that you're doing it that way. I'm going to wrap it up here. I think that's going to be the last question. But before we let you go, Dr. Camacho, if people are out there and they're interested in getting to know more about your practice, or they have questions or comments, where can they reach you?
The name of our clinic is Bogota Hairlines. So if we are in TikTok, we are in Instagram, we are in the web, Bogota Hairlines. And I'm always ready to answer all the questions, to try to help as much as possible. Yes, thank you for the opportunity.
And what's the email that they can send for consultations?
Info at bogotahairlines.com.
Info at bogotahairlines.com. All right. I want to thank you again, Dr. Camacho, for this highly informative Q&A, Instagram. Thank you for sharing those videos with me of how your team preps and implants the grafts. Thank you for sharing your protocol of how you extract grafts. I'm glad to see that there are some high quality surgeons coming from Latin America. A lot of people always ask me, what about Latin America? Is there any good surgeons? And I'm glad to see that you're one of the really good surgeons coming out of Latin America. I'm excited to see what the future holds for you. Thank you again for joining us. Thanks everybody for the questions, and we'll catch you next time.
Melvin, thank you very much. Don't forget, we speak Spanish for the Spanish speaking
Oh
population.
yes, hablo español. There we go.
Ya, pues, ya hablamos español. Sí.
All right, all right.
Thank you for the invitation, Melvin. A pleasure, really.